Hello, and welcome to Economic and Political Weekly's podcast show, Research Radio. I'm your host Abhishek, and every Monday we will talk to researchers about their research methodology and process, what they didn't include in their research, how research can further equity, and much more. Our guest this week is Professor Sobin George, who teaches at the Institute for Social and Economic Change in Bangalore. He brings an expertise in social medicine, community health, and social work. He has conducted research on questions of marginalities, social gradients of health, the medical industry, and labor rights. Professor George conducted an ethnographic study in Meenkara, a village in Karnataka, to better understand the extent and forms of discriminatory healthcare practices by upper and middle castes against Dalits in the public health system. The in-depth interviews and non-participant observation he conducted provide key details to understand the relationship between caste supremacy and the healthcare system. The insights he'll be sharing with us are based on an article he published in EPW last October. Thank you so much for joining us, Professor George.
It's a pleasure, Abhishek. Thank you.
Would you like to start by describing what researchers have argued so far about Dalit and Adivasis' access to public health services?
The research so far has tried to capture mainly the effects of discrimination, mostly through large-scale surveys and also through deriving from large-scale data sets like NFHS and NSSO with accepted methodologies. They also try to look at what are the implications of this discrimination for the health outcomes, particularly for Dalits and Adivasis, and how such discriminations affect their health seeking. Yes, these are all accepted methodologies, and we have got robust results out of it, and many studies could very well establish the linkages between discrimination and its effects on the health deficit of people through different quantitative and qualitative methods. But what we found is that there is a small problem in such approach, which I think is mostly structural and systemic and also methodology. If you look at medicine as a profession and public health services in India, there is a general narrative of medical negligence in public health services. If you look at it, is kind of quite common. If you ask anybody, they would say that yes, if you go to government hospitals, we don't get services. There is a medical negligence, absenteeism, doctors won't come in time, their behavior is rude, it is overcrowded. So we have such general problems of medical negligence which anybody can experience irrespective of his or her caste or ethnicity, which it's difficult for us as a researcher to attribute. When somebody says that I have faced medical negligence, it is extremely challenging for a researcher to attribute it to a particular behavior based on a social group. This is the first challenge. A second is a particular issue with the medical profession itself. As you know very well, medical profession is a highly power-ridden one, and there is a kind of an embodiment of an expertise in it, which is the doctor or the service provider. And mostly we tend to attribute it to the discretion of the doctor, who is an unquestionable authority in medical interaction, but is an optimal intervention for a patient. Here, there is a question of confusion between the expectation of the patient and the actual intervention required, which often is decided by an expert, which is doctor here. So this mismatch between the expectation of the patient and actual intervention required can also mask the effect of discrimination. So it's difficult for a researcher to attribute it to discrimination when one patient said, I had this problem and the doctor didn't touch me. Because sometimes it is not required, because if it is a common, if you look at common flu which is happening, the doctor can easily make it out. He can attribute, knowing the area, the particular problem, the disease pattern in a particular area over a period of time, he will be able to easily attribute it to that. That actually falls very much within the realm of clinical practice. Actually, a doctor being an expert to decide on the intervention. It's a difficult issue again. Third thing is mostly related to the problem of caste itself. Why I'm saying caste here? Because we have a lot of studies which saying caste is changing. And with the study which we conducted recently, we have seen that people tended to question caste practices. People tended to negate caste relation within in their places. The same way we can see coexisting of caste practices, caste rigidities, caste flexibilities, continuities, and all those kind of things. The caste itself is something which is highly dynamic and undergoing a lot of changes. So we need to situate when we bring caste as a category to understand medical negligence. We need to bring it in the changing dynamics. So these, I think, are the three major. Many of the studies, when you do cross-sectional studies, especially large-scale surveys, which have looked at discrimination in medical practices, this haven't actually looked at the changing nature of caste, which we think is situation specific. What we saw it in our study.
How did your research methodology attempt to address these limitations at both the stage of formulating the research plan and conducting the research?
What normally large scale surveys do, they try to restrict their questions in certain numbers. Like you'll ask questions how a particular behavior of the doctor, and they'll ask them to rate it. So we think that is not sufficient because caste practices now are very subtle. So you can't see caste practices with a normal lens. And even what we found is that people, especially Dalit, the village where we studied, they themselves, most of them, in fact, they don't believe that there is caste-based discrimination against them in health service. Why? Because there's a strong sense of Dalit consciousness and dignity, which will not allow anybody to discriminate apparently. So they will resist any forms of discrimination in that. So it is extremely even for a researcher in this particular situation to understand, is there any caste-based discrimination. So that's the reason we thought we will talk to them. And when we talk to them, many things have come out. Especially if you look at the interviews which we presented in the paper, there is a tendency of patients to attribute any kind of medical negligence to something as, I am neglected because I am a poor person. I am neglected because I am uneducated. I don't know what the doctor would say. I don't understand the meaning of the terminology he takes. Third, I'm not clean. So we can see it. The fourth is, I'm not powerful enough. If I bring somebody else along with me, the interaction can be different. We can see a lot of things, indirect attributes of caste coming in, not directly mentioning anything to caste. But if you look closely in this particular situation, there is a pattern in that. The pattern is that we haven't heard such kind of articulations from people who are not Dalit. It is what we found is that it is because the place we studied is a Dalit dominated area. We have 909 households, out of which 300 plus are from Dalit groups. And this area is also falls in between Maharashtra and Telangana region, where we have seen a lot of Dalit uprisings. We have seen a lot of Dalit mobilization. We have seen a very, very vibrant Dalit movement in this particular area. We have seen a lot of conflicts between non-Dalits and non-Dalits in the past few years. The place is something which witnessed a lot of changes in caste relations in other spheres. So this was there very much within that. So maybe because of that, since this consciousness is very strong, they don't want to articulate, it to any kind of caste practices, but definitely they face something which they try to articulate as they are being ignorant, they're being dirty. Why should the doctor touch me because I'm dirty? If you are dirty, how will they touch you? And he's articulating the people, they may explain it more to people like you, looking at the researcher, because the person who interviewed that the patient was well dressed, is from an outside area. So okay, they are attributing some qualities which are not theirs. They know that they don't have that attributes.
In our notes from the field section, we'd like you to take us to your research site, Meenkara, that's about 140 kilometers west of Hyderabad. Can you tell us about the relationship between residents of different castes and religions in different contexts and over time?
One of the objectives of our study was to understand what is happening to caste relations, because if we don't understand the changing dynamics of caste relation, we cannot place the study in its perspective. We have seen a lot of research. If you look at the caste literature coming out, we can see a trend which is coming out. There is a lot of changes happening at the ground level, which is capable of radically changing the caste relations. We would like to make sense out of that. Is that change is real or not? So we were looking for a place where we can actually kind of find out a place where there are such changes happening. Definitely, then we looked at a lot of places. The first consideration was to find out a district where the number of Dalits are more than the state average. Definitely, we have to first 3 4 states in that, and we chose Bidar. It has almost at that time when we studied 23.5%, if I'm correct, was the number of Dalits in the district. So which we thought is fine. Then the same criteria was adopted again to look at the taluks. So we used the same criteria of number of Dalits. Third was because there are a lot of theories of change in caste relation. One is the numerical dominance. If you look at the caste scholarship by M. N. Srinivasan and others, there are certain prerequisites they say in changing caste relation. One is the numerical dominance. Yes, in this particular case, there are the village, the place we selected had clear numerical dominance of Dalit. Second is movement from agriculture to non-agricultural occupation. Even if the non-agricultural occupations are not rewarding, it's when you say non-agricultural occupation, we should not think that they are working in a better place. No, they may not be working in a better place. They may be moving out. They may be working as in a market or maybe working somewhere else in a railway station. But we can see a movement because traditionally agriculture occupation is highly caste driven. There is a movement from agriculture to non-agricultural employment. In our particular case, if you look at three generations, we looked at the occupations of three generations in several families. First generation, I mean, if they are working, they are mostly tied with agricultural occupation. If you come to the second generation, it's a mix. We can see a movement, but it's a mix. People still work in agricultural lands. Yes, the relationship in agriculture employment has changed because it's not like that you can have a clear pattern kind of relationship because availability of workers also would matter with a lot of other things. So landlords are also their behavior is also changing, but we can see still they are kind of depending on them. And third is look at the households where we studied. When you come to the third generation, we can see almost a complete shift of the third generation to non-agricultural vocation, largely driven by education and other. Even if it's available, they don't want to do that. They don't mind. They don't mind even if it is not stable. They prefer working in taking up such occupation to working in agricultural fields. Of if when you come to the third generation, the third thing is the political mobilization. As I said earlier, the area was it was in newspaper 3 years before we conducted the study because there was a conflict between Dalit and non-Dalit group because there some of the non-Dalit group they tried to disgrace Ambedkar's statue and there were a lot of conflict and they had to deploy police force. The place was under tension. They declared 144 and all. The place is known for its Dalit mobilizations. DSS was very strong. It was cast as I said earlier. There are a lot of changes. If you look at the public spheres, as many studies have already noted, there is a decline of caste-based practices. It's difficult for you to obviously locate caste practices outside, but if you look at more intimate practices, you can see there is no intertwining. People say that yes, earlier we were not invited for the wedding of the upper caste. Now we are invited. They also say that earlier we didn't have the courage to invite them for wedding parties in our house, but now we invite. That's not over. But say that even if we invite them, we arrange food for them in a different place and the type of food we serve is also different. So we can see both a continuum and discontinuity in that. And also, if you talk to the youngsters, especially those who are educated and doing like Anganwadi workers, and they tend to be slightly assertive. If I talk to several Dalit women, especially youngsters who are into modern occupation, what they say is that there is no caste, and we are not experiencing it. We could hear narratives of complete negation of caste practices. Especially, they said that there's a stream there where everybody uses to wash their clothes. They said that earlier the upper caste people used to occupy the upper side of the stream, and we were in the lower side, and we were not allowed to go there. Now things are reversed, and we are actually in the upper side. They are in the lower side, and we are controlling it. It's a kind of a narration which actually negated caste practices or showed their capacity to challenge it. And second is rather, if you look at old generation, they said there are changes, as I said earlier, inviting to home, going their home, but with a lot of restrictions. We also found in third kind of narrative, which is changes with assertion and resistance. People, especially again youngsters, they said that yes, caste practices are there. It's not like that it has these have completely gone, but we know how to handle with that. We know how to deal with it. So it reflected a kind of a sense of confidence, and they know that they can resist it. They have developed a kind of courage to resist it, and that's how they dealt with that. And there is another category of explanation which completely negated the change. They said that nothing has changed significantly. Obviously, there are a lot of changes in the forms, the way the manifestations have changed, but the essence, the core of the caste is still there, because if you cannot still intermarry, and if they may if you are in same political party, they may behave well within that group, but when you try to interact in their personal spheres, you will face discrimination. So the last group, they said that yes, there are a lot of changes in the manifestation, but the core, the essence has not changed at all. We got a kind of mixed picture of caste-based practices in the village. What we found is that caste definitely has come out of its structures, but it came out from the structures, and but it tries to accommodate itself to the spheres and situations. Caste is actually more of situational. It can take its specific form depending on the situation. That's what our study about caste practices in health services would become more important here, not because just caste, because we have one more powerful structure here, which is medical practice. So on one side we have caste, which is a very strong social institution, structured power ridden institution. Same other side we have medical practice, which is also, it's a very powerful institution. It would be interesting to understand how these two structures interact and give a different meaning to caste practices altogether.
You found that a lot of the executive positions in local public health facilities were occupied by dominant castes and other non-Dalit castes. Is there a role that reservations could play in changing the scenario and reducing discrimination?
We have a general deficit of practitioners in public health services in the rural areas, and that problem will not be solved by reservation. Reservation can definitely bring social justice into that particular service when we think it from the perspective of the people who are joining the service. But this is another dimension of social justice, especially when we think from the perspective of the people who are seeking treatment. There, I think we need a different approach altogether. That's what I think. I don't think reservation alone can solve this problem. But definitely, as I argued, if we have more personnel from that particular group, there are changes. We have seen the lessons from Uttar Pradesh, especially among ASHA workers, what they did. There is definitely people from other castes will not go to the lower caste locality. So they recruited people from the same caste to serve the same place, the same locality, same city. It actually kind of worked. There is another argument. It is we are actually doing an experiment to recreate the caste. Yes, we are one way recreating the caste because we are kind of normalizing that the practice based on caste. But health service is something which is we need. It has its own urgency. We have to make sure that they visit the household, they give proper health education, they give vitamin supplements, they give other services which are supposed to be given by them. So we prioritize the health emergency over other consideration. If there is a problem of caste being reproduced in such activities, I agree with that. But what I found is that there is an embeddedness of caste and medical science here. It's if there are formal, and I already argued this in the article. Formal is like yes, there are disproportionate representation of non-Dalits in key health services provision. Like ASHA is very important. Multi-purpose workers, doctors, yes, still we can manage, but other staff nurse, ASHA, and other things we can see and a disproportional representation. Which in fact we can see, how do they recognize their own people. It matters a lot. If I don't know whether you have an experience of going to a public hospital. It's no usually crowded and it's very difficult. I mean, you need to have go there with a different sense of mind, state of mind, because you have to wait. Anybody can misbehave with you. There is no place to sit. It may be smelly, and you have to. A lot of problems are there. But you can see people are being prioritized in a queue if you know somebody from the health service. That social capital, in fact, would work in a different way. The same way that social capital is, we have seen that the rich upper caste, not upper caste, middle level caste group, I don't want to say the name of a particular caste here, but they may not directly access service from PHCOCS, but for their tertiary care needs like surgery, dialysis, renal care, other things, what they do, they take reference. You need to get references from lower level to get access to tertiary hospitals in public sector, where the treatment is highly discounted or free. Even if they don't access here, they use the same social capital and network to access the better services in tertiary care. And we also see a disproportionate allocation of resources within the village. As I argued in the paper, there are three Anganwadis in this particular village. One is in a Dalit settlement, and other two are in the non-Dalit settlements. And there are huge differences in the quality of services and infrastructure available among these Anganwadis. Two in the non-Dalit settlements and one in the Dalits. This again is a formal embeddedness. Informal embeddedness is the network they use. I know somebody there, so I can use it. That's why one of the little small patients said that if I go directly there, an emergency care somewhere to a doctor, he may not be very nice to me. He may not give me proper care. But if I go with the Dani, and is maybe a middle level caste person in the village who has some kind of network and power with people, he may take my case more serious. So these are informal embeddedness of caste. Caste matters. That person is not saying that I won't get treatment. I will get treatment if I take that person along with me.
Uh-huh. You've already started talking about this, but can you share your findings about how Dalits experience better healthcare services when they take help of dominant caste members or access private facilities? Or is it the case that caste supremacy changes the way it functions in both of these options?
I'm not saying that everybody who goes to public services would get good treatment, but there is a tendency that we have seen a person, if it's not from a particular group, might be more prioritized even in a resource crunch situation. In private hospitals, such things won't happen normally because there is enough resources to take care of. In the resources, what I mean is time, availability of doctors, availability of treatment facilities, availability of medicine. Since you are paying, since this is something based on economics and profit motivated, yes, there are ways to control it. But still, what we found is that the information. Of course, this particular study did not, in fact, specifically look at discrimination in private provisioning, but I think, which we can actually study later, what I think is that even such thing can happen in a different way. In terms of the way you talk to me, you have to understand the nuances of the doctor-patient interaction. Actually, we are doing a study in that how especially something like shared decision making, which is an important domain now in doctor-patient interaction, especially to reduce affordability and improve quality and to meet the unmet needs of the patients. Imagine a situation in which a poor Dalit and a non-Dalit person interact with a medical practitioner in a private care system, where it is possible that if the doctor-patient interaction is fine and we have certain agreements for the quality for the intervention, especially if it is a surgery, what kind of surgery, where should we do it, how do we do it, what kind of medicines can be prescribed. He is diabetic, there are medicines, same kind of generic medicines, but huge variants can be there across brands. The doctor decides what kind to be given. So there are various ways in which a shared decision making can come in.
Did you notice any trends where Dalits of specific identity, such as women, queer, or poor Dalits, were discriminated more severely or in different manners?
Good that you asked that question. That also opens up further area of research. How we can look at this across further subdivision. But in this particular research, what we have seen that there was a difference in the experiences of people from within Dalit community across categories such as poor and rich, men and women, educated and uneducated, connected or not connected with the significant person in the society. Created discrimination is little more complex term. I don't have the courage to use it here, but yes, it is. There are even differentiations within a group, but the differences are not that significant so that a rich patient or a connected patient or an educated patient or a man can always access services in a better way. There is a permitted level, even that these persons from this group also can't cross that permitted level. Definitely, there is within that there are differences, but it is not great enough to cross the threshold of niche. If you compare the experience of a rich privileged man in a Dalit group and a rich privileged man in a non-Dalit group, it's huge.
You've made it clear that there are all these different ways that discrimination is meted out to Dalits by dominant castes. Can you share some ways that dominant caste practitioners justified such behavior?
We haven't asked, as I said, directly to the practitioners, why do you behave like that? I think it's already prevalent in the society that the doctor is an unquestionable authority who has more knowledge than us. Wherever, whatever you are, I mean, even if a rich educated person interacts with a doctor, there can be a difference in power relation. You and me interact with a doctor, definitely it's going to be huge power relation because based on what we know and the technical term she or he uses with us. So there is definitely a power difference. That sense of power differences is accepted. That power transcript is already accepted. It is already well percolated. And not only well percolated, people have internalized that. What we have seen in our study is that some of our, definitely some people objected to a particular practice of a doctor, but others, what they did, they normalized it. I mentioned some of the instances before, like they said that doctor perhaps knows much about it. Who am I? I don't know. Even if he explains it to me, I won't understand. Why should he explain it to me? I think it's fine. Let him do. He's like, we have also a tendency to have higher. I mean, our admiration to a medical practitioners can go up to the level of worshipping him or her. We have seen that in villages, people, if they really like the doctor, they tend to even literally worship that person.
Would it be possible to share some of the unanswered questions that you continue to investigate?
One of the questions, as I already said, which we would like to know, explore further, is look at how medical interactions and shared decision making happening between across different social. Is there any social group angle to that? That is one question. Second question is that we have found a very strong dominant narrative of dirt in the study. Many people, as I said, they said that doctor discriminated against me because I am dirty. Same way, if you look at the discourses of public health, it finds quite contradicting. It's a kind of matter out of place. One side we have a strong notions of hygiene within the health, and same concept of hygiene is invoked to deny services. So we would like to look further into it in the politics of dirt in medical interactions. And third is how these kind of experiences are different within subgroups. Possibly, I don't know the fourth questions, which I just got a cue from your question, and how can we actually look at from the perspective of the medical practitioners? How do they see it? It is difficult. It is extremely difficult, but yes, I thank you for that clue. But definitely, the first one which I said, shared decision making, because it affects affordability, especially when it comes to the non-communicable disease entities, for instance, cancer and others. Though shared decision making can make a lot of impact on affordability.
Right. Right. And this is a question we ask all our guests on the show is, what do you see as a role of your academic research in terms of furthering equity both inside and outside institutional spaces?
It's a heavy question. In fact, I must say there is no element of equity addressed in our study. I would say it's unethical. We have to make equity as something part of our knowledge production exercise. especially in social sciences. If you look at medical science, even if I don't know whether they would really follow, but they'll ask what is the social benefit of your particular study. Maybe these days investigators are smart enough to say and write something about whatever they think is yes, it's going to help people, it's going to find a kind of good intervention for corona, whatever. People can attribute in their own way, but at least they are bothered about that question. Ethical concern is there in that. But surprisingly and shockingly, in social science research, if you look at the social science institutions, I don't know how many institutions and universities conduct social science research will have to submit their papers through ethics committee. I still have my doubt about it. I think the entire question of social relevance, policy relevance, whatever you ask, should be very much part of the knowledge production exercise itself.
And is there anything else you'd like to share that I haven't asked about directly?
One of the things probably you might haven't covered is the way the Dalit bodies are identified. We call it immediately perceivable attributes. Yes, if you ask 5 questions, definitely your caste will come out. But there are other than that, there are other elements. And I found it extremely interesting and also shocking how odor, smell is invoked to identify the caste of persons. It just came out in our general discussions how caste bodies, the look, the Holaya look, or the Madiga look, or the Vadara look, or the Lingayat look, how such corporeal objectifications happen, and it is invoked to identify somebody, which have implications in other spheres. If imagine a situation if the Dalit patient goes, maybe in this particular case, if a person goes to PHC, which is actually in Meenkara, CHC is closer than the PHC. Imagine that if PHC is in another village, imagine a person who is going to that place. Nobody knows him because in Meenkara, everybody knows their identity. It's not difficult for a doctor. Definitely at the registration clerk, you will have to give your caste background, your full name. And when it comes to a doctor, your full name may not be there. Doctor may not have time to ask any questions which will explicitly reveal your caste identity. But there are easy way to identify your caste with your dress, with the way you speak, and body odor, which was quite surprising. That's why I thought I shared with you. I would like to pursue this project of dirt, how dirt is invoked in medical interaction.
That was a lot of rich and detailed information. Thank you so much for sharing it with us, Professor George.
Thank you very much. I think I could also speak a little more than what I published in the paper. Thank you for the opportunity.
What I found quite interesting from all of what Professor George had to say was honestly the research methodology. Limitations of India's public health system are stark and visible, and yet, as Professor mentioned, in situations when resources are scarce, they are allocated to benefit the health of those from the dominant castes. I do recommend reading the entire article written by Dr. George, especially since it contains direct quotes from Dalits in Meenkara describing their experiences of subpar healthcare. I've shared the link to it in the description of this podcast. Next week, Professor Virginius Khaka will talk about tea plantations and the manner in which workers organize themselves to struggle for living wages and humane working conditions. We learn about how the plantation system emerged in South Asia and the enduring role of the state in safeguarding the interests of estate owners rather than workers. Do subscribe to us on your preferred podcast streaming platform so that you don't miss out on that and our future podcasts. We are available on Spotify, Google Podcasts, and Apple Podcasts. And since we're new to podcasting, we would love to hear from you about how we're doing. Send us an email at social@epw.in or ping us on Facebook, Instagram, or Twitter with your feedback. And if you like what we're doing, do share with interested folks. Take care, and until next week.